First of all, I'd like to thank the organizing committee of the Endo Foundation, in particular Professor Sechkin and Professor Martin, for inviting me to this excellent meeting in New York City. Ladies and gentlemen, dear audience, in the morning session we had some controversy about the question if medication at all is needed in patients with endometriosis or surgery is the predominant approach. And now I come with the GnRH antagonists. Ladies and gentlemen, within the next 15 minutes, Mike, does it work? Or? Okay. Within the next 15 minutes, it's not much time, I tried to take you on a foresight into endocrinology. Secondly, I have to convince you that the GnRH antagonist is a product that works on endometriosis and that potentially the brain works better. This is a very provocative title of my lecture. So let's dive into endocrinology, but I have a disclosure. So as Dr. Sechkin told us in the morning, patients first, so we have to tailor a personalized medicine to our endometriosis patients. We all know these different pleiotropic appearances of endometriotic lesions. And of course, surgery is the predominant approach, not only for diagnosis, but for remove these lesions for a better life quality of our patients. But we have to take into account that endometriosis is more than this. It is a chronic, inflammatory, very complex autoimmune disease. And if you go into endocrinology, we know these are the key features of the impaired endocrine system of patients with endometriosis, the estradiol dominance, the elevated aromatase activity, the imbalance of the estrogen receptors, alpha and beta, the progesterone receptor resistance was mentioned before, and an immunological disbalance. So what do our big societies recommend to do? If medication is needed, oral contraceptive, progestins, and GnRH agonists. So most widely used are oral contraceptive or the progestins. What's going on with the progestins? So I start with progesterone, which is something different. And to go directly into the nervous system and the brain, progesterone exhibit with very interesting, in a very interesting manner. It leads to relaxation, anxiolysis, learning enhancement, improved cognitive functions, pain relief. So that means analgesic effects. Because of what? Because progesterone, and this is the native progesterone, is converted into allopregnanolone. And this is important. So this allopregnanolone activates the GABA receptor, ends up in an elevation of the neurotransmitter activity and elevates the serotonin level. Also, progesterone synthesis could be shown and confirmed in the central glial cells and seems to be responsible for the regeneration of the myelin sheath. But this is true for native progesterone and not for the most of the progestins we apply to our patients. So we can encounter a lot of side effects. You can read it. Acne, bloating, breakthrough bleeding, breast discomfort, depression and dizziness, and so on, headaches, irregular bleeding, lethargy, moodiness, and so on, and so on, and so on. So the question is that a therapeutic success or not? So we get our patients rid of this so-called brain fog. To go on with the scope of my lectures, the GnRH. Gonadotropin-releasing hormone was firstly characterized by Andrew Shelley from New Orleans, and he got the Nobel Prize for that. And GnRH acts in a very specific manner in the pulsatility. In this, the frequency and the pulsatility was firstly described by Ernst Nobel and Ludwig Wild in the 80s from the Department of Physiology in Pittsburgh. Ludwig Wild is still working. I met him a couple of weeks ago. So, what is all about the GnRH receptor system? So it's a regulator of the HPO axis. And there's a vast distribution in peripheral organs and tissues, and also in the central nervous system. The GnRH guides reproduction, is responsible for the HPO axis and for the onset of the cycle and at the end of the fertility capacity. But also, it has an impact on the brain and the nerves. That means neuroprotection, neurogenesis, cognition, sexual behavior, and aging. Very interesting. So, what do we have? We have the GnRH agonists and the antagonists, both synthesized by Andrew Shelley from Chile. But the GnRH has turned out not to be so very efficient and beneficial because we have the flare-up phenomenon, we have a complete down-regulation, desensitization of the receptors, leading to a long-acting hypogonadism. Much more elegant is the mode of action of an antagonist, a classical competitive receptor blockage. Gives us the opportunity to work or to apply this antagonist dose dependent. For what? Because we want to meet the so-called therapeutic window. In cases of endometriosis means the well-being of patients, so that we have a basal estradiol secretion on the one hand, better bone density or no effect on the bone density. And on the other hand, endometriotic lesions should not progress and should lead to an atrophy of endometriotic lesion. And this is possible with estradiol concentration of approximately 40-50 picogram per ml. So our group could confirm this therapeutic window using a GnRH antagonist. It's very, very long ago, and nobody believed us. But nevertheless, so what we did, we applied cetorelix once a week subcutaneously, and we could achieve this oscillation around 50 picograms estradiol per ml. And these are the effects of the antagonist. Pain reduction, not hot flushes, no hot flushes, like before using the agonist. We had a sufficient steroid secretion, no AdBac was needed, the bone mineralization was stable, and we could confirm the atrophy of lesions. And now, more than 50 years later, we have the oral antagonist, a real interesting product, and could be confirmed that the antagonist works as we want it for our patients in pain patients of endometriosis. And there's a very, very nice paper from Taylor from the Yale group using elagolix, the first oral GnRH antagonist. And he also could confirm the dose-dependent manner, so the higher the concentration of the antagonist, the lower the estradiol secretion. Now, I will come to the clue of my lecture. So, what is the antagonist? What is GnRH itself doing to the nerves and to the brain? And there seems to be a putative central impact concerning mood, memory, and sex drive, which is very important, especially for our endometriosis patients. And the GnRH and the antagonist exhibit action on the hippocampus, the amygdala, and the thalamus and the gray matter. So the hippocampus is explicitly important for the memory function. So indeed, in the brain we have estradiol receptors, we have GnRH receptors, and under the pulsatile secretion of GnRH, a local estradiol production is going on in the brain, supported by a sufficient concentration of estradiol from the periphery. So this is needed, that the local estradiol production in the brain takes place. There are quite interesting papers from basic research, on the one hand, from 2016 by Nelson and co-workers. They could show us indeed that the circulating estradiol regulates the brain-derived estradiol via actions at the GnRH receptors to impact memory in ovarectomy rats. The same could be shown in a paper from 2020 by Marbuti and co-worker, that the GnRH itself has protective effects against amyloid-induced cognitive decline. So the pulsatile secretion of GnRH is of importance. Shelley himself could show this in a nicely engineered mouse model that cetorelix blocks beta amyloid 25-35 with an antidepressant-like action, anxiolysis, and a memory consolidation. And what is happening when we use the GN antagonist? The clue of all of this, that on the one hand, we give the antagonist in a dose-dependent manner. We have a specific half-life time, and not all receptors are bound. That means we have a sustained GnRH action, especially in the brain. The simple doctor like me, better to say a clinician, what a clinician can learn from this. First, using the GnRH antagonist guarantees us pain reduction, and this is of foremost importance. As we know that oral contraceptive and progestins, they are effective, but they do have side effects. The antagonist is selective and effective and has a sustained estradiol secretion, while a sustained GnRH pulsatility, which is of utmost importance. So, given a GnRH antagonist could give us a kind of concert of a local estradiol secretion in the brain together with GnRH itself. So that means for me that the antagonist offers a balanced, harmonic treatment. So what can be expected? Pain relief, of course, this is of importance. No mood changes, improved cognition, better memories, and a better sex life. How can we confirm this? So I think it would be a very good opportunity to measure the neuroplasticity in the brain function using functional MRI, brain imaging. So that should be done. And of course, ask our patients, talk to them. How is the life quality under the GnRH antagonist? Our group treated about 120 patients and we had quite good success, except 1 or 2 patients where this doesn't work. So thank you very much for your attention and your patience. This is it.